Good evening, everyone, and thank you for joining us tonight for Illinois Bone and Joint Institute's 51st virtual YMCA Education Series program with the North Suburban YMCA. My name is Karen Brownlee, and I'm a personal trainer and the adult program coordinator at the NSYMCA in Northbrook, Illinois. This evening's presentation, entitled Healthy Bones, Understanding Osteoporosis, is just in time because tomorrow is the first day of National Osteoporosis Month. It is being recorded so that you will be able to revisit it again. Please feel free to tell your family and friends about this program so that they too can view it once it is posted on the IBJI and NSYMCA websites. The World Health Organization defines osteoporosis as a systemic skeletal disease characterized by low bone mass and microarchitectural deteriorations of bone tissue with a consequent increase in bone fragility and susceptibility to fracture. That's a mouthful, and it does make sense when you break it down. But what does an osteoporosis diagnosis mean for those who receive it, and what can we do to preserve bone density? Tonight, we have my favorite Illinois Bone and Joint Institute physician, Andrew R. Benck, MD, with us to help us understand osteoporosis and how to keep our bones as healthy as possible. Why is Dr. Benck my favorite? Well, I'm happy to answer that question, and it's because he is part of a team that includes myself, Dr. Benck, and a firefighter from the Northbrook Fire Department named Ted Aquino. This fabulous team is taking balance and fall prevention on the road through a program we created called Balance Strong, Live Long. Together, Dr. Benck, Ted, and I visit local senior housing facilities, senior groups, and senior centers, and really anyone interested in reducing their fall risk and improving their balance, and we bring them a 1-hour interactive program teaching folks how to build better balance and prevent falls. Another reason he's my favorite is that Dr. Benck is an all-around great guy, which I think you will learn tonight. Okay, so moving on. Dr. Benck is a board-certified rheumatologist practicing at the Bannockburn IBJI location who specializes in the treatment of autoimmune and musculoskeletal disorders such as rheumatoid arthritis, osteoarthritis, lupus, serodegenerative spondyloarthropathy, vasculitis, myositis, sarcoidosis, osteopenia, and of course, osteoporosis. He earned his MD at the University of Illinois College of Medicine at Chicago and completed his internal medicine residency at Cedars-Sinai Medical Center in Los Angeles. Dr. Benck also worked as a hospitalist at UCLA prior to completing his fellowship in rheumatology at Rush University Medical Center in Chicago. Dr. Benck's practice focuses on diagnosing and treating adults with autoimmune and musculoskeletal conditions, and he believes in shared decision-making with his patients, which allows for a tailored approach toward the most effective treatment plan that both he and his patients are comfortable with. His goals for each patient are to control disease activity, improve functionality, increase comfort, and finally, to improve quality of life. According to Dr. Benck, great patient outcomes are achieved through communication and shared decision-making. He strives to create and nurture a physician-patient relationship and partnership with every patient and to generate an effective, individualized treatment plan. To do that, Dr. Benck employs the latest diagnostic tests, medications, and procedural techniques to ensure high-quality care for each and every patient. During Dr. Benck's presentation this evening, you might find that you have questions for him, which he will be happy to address at the end of the program. Simply type your questions into the questions section on your screen, and I will receive them and relay them to Dr. Benck immediately following his presentation. I do ask that you please keep your questions general, as Dr. Benck will not be able to address individual concerns without individual consultation. If you do have self-specific questions, please contact Dr. Benck via one of the options that will be listed on the slide shown during the question and answer portion of the program at the end of his presentation. One last thing before I turn the evening over to Dr. Benck, please mark your calendar for our next IBJI and YMCA Education Series program on Wednesday, May 22nd at 7 p.m. Dr. Douglas Solway will answer our questions about forefoot pain. Thank you again for joining us tonight, and thank you, Dr. Andrew Benck, for your time and effort in putting together this program to educate us about healthy bones and help us understand more about osteoporosis. Dr. Benck, please take it from here.
All right, thank you so much for that kind introduction, Karen, and it's an honor to work with you and Ted on the program that we've developed. Let me just go ahead and pull up my slideshow here for everybody. Give me one moment. Okay, we're ready to rock. All
Looks
right.
great.
Perfect. So I have no disclosures for this talk this evening. Here are my discussion objectives. So we're first going to start by talking about the process of normal bone changes over time. We're going to move into DEXA scans, what they are and how they're used. We'll talk about risk factors for osteoporosis. We'll talk about the importance of vitamin supplementation. And then finally, we'll move on to pharmacologic treatment options. All right, so getting started, what are bones made of? So they're about 70% made up of something called hydroxyapatite, which is just a mineral. It's composed of calcium and phosphorus. 22% of the bone is made up of protein. And usually it's not protein like you think of like chicken or steak or something like that. It's type 1 collagen. That's 95% of that protein. 8% of the bone is water. And then there's a whole mishmash of other stuff making up about 5% of the bone, mainly things called proteoglycans, which help absorb compressional force. So there's actually two types of bones. The first type is called cancellous bone, and another name for this would be spongy bone or trabecular bone. This makes up about a quarter of the bone. It's integral to regulating the amount of calcium in the bloodstream. It's where stem cells live and where blood cells and platelets are made. It's the more flexible part of the bone, and it's called spongy bone because of its sponge-like appearance. The other 75% of the bone is made up of something called cortical bone, which is also known as compact bone. And as you might imagine, with the name compact bone, this provides mechanical strength to the bone. It's much stiffer and stronger than the cancellous bone. So both the cancellous and compact bones are porous structures. It means they have holes in them. The amount of space between those pores is what gives the name cancellous and compact. So cancellous has large porous spaces. Compact has much smaller porous spaces. And the combination of the two types of bone structures is really what gives our bones strength without being brittle. And this is due primarily to the flexible component of the cancellous bone. So this is a pretty cool picture here that really illustrates the difference between the two types of bones. And on the left, you'll see an animation, and on the right is a real specimen of bone that's been dissected. So basically what you'll see is that in the middle of the bone, that's where the cancellous bone is, or the spongy bone. And if you look in there, it kind of looks like a sea sponge almost. You can almost see those pores with the naked eye. And then when you move to the outside of the bone, which would be the type of bone that you would see, let's say you were looking at the pathology lab and there was a specimen on the table that had not been cut in half. That's the type of bone that you think of, that white outer surface. That's the cortical bone. And as you guys have all known, if you look at that type of bone, you don't see little holes in it. So those holes are very tightly compacted together. So how are the bones maintained? So there are two types of cells that are really integral to maintaining our bones. The first type is called an osteoclast, and the second type is called an osteoblast. The osteoclasts are the cells responsible for breaking down old bone. So when we're born and our skeleton's growing, we don't just get one skeleton and the cells never maintain it. There's always cells maintaining that bone. So the osteoclast portion breaks down the old bone. The osteoblasts, which are the other type of cell, they're responsible for creating new bone. And when these two cell types function properly and they're in balance with each other, it allows the bones to serve us well without issue throughout our entire lives. So I apologize for the picture on the right. It's a bit small, but I did want to put it in because I think it really illustrates this bone maintenance steps very well. So normal bone maintenance consists of 5 steps. And these steps are occurring in different phases at all times throughout the bones of the body. And this process replaces the entire skeleton roughly every 10 years, which I find amazing. So I'm 40 years old, so I've had 4 skeletons. The first phase of the 5 steps is called the resting phase. And in the resting phase, as you might imagine, not a whole heck of a lot is happening. The bone surface is covered by a protective layer of bone cells called lining cells. And it's really in homeostasis, meaning that there's no active destruction or formation going on. The second phase is called the resorption phase. And during the resorption phase, those osteoclasts, which kind of degrade the bone, they come and invade the bone surface and they start eroding away at it. They dissolve the mineral in the matrix of the bone and they leave these little cavities. Once they're done creating those little cavities, the phase is now resorption complete. The fourth phase is called formation repair. And as you may imagine, this is where new bone gets laid down in those little divots made by the osteoclasts. So basically what happens is the osteoclasts come along in step 2, they chew up the bone, they make these little cavities, and then the osteoblasts follow right behind them and they replace the bone. And then once they've replaced the bone, we call that repair complete. That's the final step. And then this process just repeats over and over again in different phases, in different parts of the bone all over the body. So osteoclasts destroy more bone than they should when your body's minerals, vitamins, and hormones are not balanced. And when bone destruction is greater than bone formation, the bone density and strength decreases over time. And when the density and strength of the bone decreases to a certain extent, we call that osteoporosis. This is another really good picture here on the right. So normal bone matrix, you can probably pick it out of the lineup here, even if it's not labeled. Those little pores look very closely knit together. It looks like that thing would be hard to break. On the far right-hand side, you see that the pores are massive and you just have these little tiny septations, or these little lines of bone that are preventing things from breaking. That's osteoporosis. So what regulates bone maintenance? Well, a couple things, but some of the most important are calcium, vitamin D, and parathyroid hormone. And these help regulate calcium levels in our bodies. This regulatory process is directly tied to bone health. Vitamin D helps the body absorb calcium from the diet. That's the importance of vitamin D. If calcium is low, either due to low vitamin D, meaning that your body's not able to absorb the calcium, or low due to dietary intake, meaning you're not eating enough foods that contain that, then the body senses this and they release parathyroid hormone. And this encourages the body to release calcium. And that calcium is stored in the bones. So the way I think of the bones is I think of them as a strategic reserve for calcium. So if there's not enough calcium in the blood, then the body's going to take more from the bones. And as you can imagine, when we first talked about what the bones are made of, part of them contains a lot of calcium. That hydroxyapatite is mainly calcium. So over time, as the calcium is leached from the bones, this can lead to decreased bone density and finally to osteoporosis. So I'm going to take you guys to medical school here for a minute. So this is a pretty good diagram, just illustrating how this all fits together. So up at the top, you see that Ca, that means calcium, and the little down arrow means low. So low calcium is going to stimulate the parathyroid glands, and those are 4 little glands that sit on the back of your thyroid gland. And when they stimulate the parathyroid glands, they release the parathyroid hormone, and that acts in several ways. So the parathyroid hormone is going to tell the bones that basically they need to release calcium. And it's going to tell the kidneys that they need to increase the calcium reabsorption so that you're not peeing out so much calcium. And then on the other side, we have vitamin D. So food and your skin. So food, you can eat vitamin D. And of course, when you go out in the sun for short periods of time, ideally, your body's going to make vitamin D. And that's going to stimulate eventually the gut to absorb more calcium. All right, so vitamin supplementation is important. Yes, it is. So the Bone Health and Osteoporosis Foundation recommends the following. So women age 50 and younger should be taking 1,000 milligrams of calcium from all sources each day. So that would include supplements and diet. And women over the age of 51 should get 1,200 milligrams. Men age 70 and younger should get 1,000 milligrams of calcium. And if you're 71 and older, you should be getting 1,200 milligrams. There are 2 types of calcium supplements. There's calcium carbonate and calcium citrate. Calcium carbonate, you may know better as Tums. So calcium carbonate is 40% absorbed, but it must be taken with food, and it's not well absorbed if you're taking any sort of acid reducer for acid reflux. So if you are, you'd want to take calcium citrate instead. The issue with calcium citrate is that it's only 20% absorbed. But of course, there's not as many limitations. So both of these supplements are really good. You just have to be cognizant that not all of it is absorbed. So these are some easy ways to get the calcium that you need through diet. And what I always tell my patients is you should Google dietary sources of calcium, because there is a massive list of foods with all of the milligrams of calcium associated with those. So if you really try and you really don't want to take supplementation, you probably could get the full amount of calcium that's recommended by diet alone. But as an example, spinach has 250 milligrams of calcium. 1.5 ounces of cheese has 250 milligrams. The one I like the most is almond milk, and that has 440 milligrams. And you can kind of go down the line here if you Google dietary sources of calcium, and you'll see. The one thing that I do want to stress is that diet calcium, meaning the stuff that you eat and not the supplements that you buy, is the best source of calcium, because the dietary calcium is 100% absorbed as compared to either the 40% with calcium carbonate or 20% with calcium citrate. So kind of moving on here from calcium to our other very important vitamin, vitamin D. So the Bone Health and Osteoporosis Foundation also recommended that adults under the age of 50 get 400 to 800 international units, or IU, of vitamin D every day, and anybody over 50 should get 800 to 1,000 international units of vitamin D every day. So this is a kind of a certainly not a complete list, but a good list of foods rich in vitamin D. So the biggest one here that you can see is salmon. Salmon's great for all sorts of reasons. It has healthy fats. You know, it's very good for you. It's anti-inflammatory. However, it also has almost the entire amount of vitamin D that you need per 3.5 ounces. So it has 988 IUs of vitamin D per 3.5 ounces. And then, as you can see here, there's other foods, but they don't have nearly as much. But again, I always say, go ahead and Google dietary sources of vitamin D, and you'll get a whole laundry list, so you can kind of make your diet what you need it to be to get the amount of vitamin D that you need. All right, so moving on. When does bone density and strength peak? So despite bone maintenance with those osteoclasts and osteoblasts, our bones do reach a peak bone mass and bone strength. And that happens in our 20s to very early 30s. Bone mass slowly decreases after this time. This decline accelerates in women at menopause, and this is because estrogen is very protective against bone loss, and it really helps keep those osteoblasts and osteoclasts functioning in harmony. But after you lose that significant amount of estrogen when you go through menopause, this protection ends. So bone mass declines in both men and women, and that's something I want to stress, is that everyone is losing bone mass from the time they're age 30 and on. Women tend to have a sharper drop-off after menopause, but men are consistently losing bone density. So guys, I don't want you to think that you cannot get osteoporosis. That would be a fallacy. And we wouldn't want to miss anyone getting osteoporosis because, as we'll see later, that can cause fractures. So there are kind of two flavors of, I guess I would say, not normal bone density. So first you have normal bone density. The second step, when you're slowly losing the bone density, is called osteopenia, and I kind of think of this as soft bones. And then finally you reach osteoporosis, which is what I think of as brittle bones. So osteoporosis, we finally made it. It can be defined as a disease of the bone where the density of the bone decreases to such a low level that there's a high risk of fracture with minimal or even no trauma. And an example of this would be a fracture occurring as a result of a fall from a standing position. So what we call a ground level fall, meaning you're not, falling off your roof or a ladder or a chair trying to change a light bulb or something like that. And fragility fractures is what we call these osteoporotic type fractures. They can happen basically without any falls as well. So I've seen people have fractures from sneezing, they've had back fractures, or they just get compression fractures of the spine doing nothing. It just kind of happens spontaneously. So osteoporosis related fractures are responsible for 430,000 hospital admissions per year, 2.5 million medical office visits per year, and 180,000 nursing home admissions per year. And I have to say, this data is now likely very outdated. This is from at least 10 years ago. So these numbers are probably significantly higher. This, of course, creates a large economic burden and strain on our medical system. In 2005, osteoporosis-related fractures were estimated to cost the healthcare system $17 billion. But who really cares about this money? Ultimately, what we care about is the people impacted by these fractures and the quality of life that they have following one of these fractures. So I like this slide a lot. This is from the National Osteoporosis Foundation. And again, this is 2010, so this is likely outdated and the numbers are probably higher. But what I want to draw your attention to is that on the left, you have osteoporotic fractures. And you can see that's a pretty big bar, 1.5 million basically. And then on the right, you have things that we worry about a lot more typically as human beings: heart attacks, strokes, breast cancer. But you can see that the amount of osteoporotic fractures dwarfs heart attacks, strokes, breast cancer combined. So this is a very common thing that's happening, and a lot of people don't realize that it's even a disease. So about 1 in every 2 women will have an osteoporosis-related fracture in their lifetime. And this is, we get to that stage where 50% of females will have a fracture around age 80 or greater. About 1 in every 5 men will have an osteoporosis-related fracture in their lifetime. That's similar around age 80 is when you reach that. It's not to say you can't get one earlier. Many people do, but that's kind of when the risk is the highest. So of course, risk goes up with age. Treatment can reduce the risk by about 50% on average, and that's really what we hope for. In medicine, unfortunately, with our pharmacologic therapies, nothing is perfect. We can't reduce that risk by 100%. We can't fully prevent it, but we can reduce the risk by about 50%, which is pretty good. Of course, many patients who have these fractures will fully recover from that event, but many are left with chronic pain and disability. And for some, these fractures portend a very poor outcome. Hip fractures result in a 10 to 20% excess mortality rate within 1 year of the fracture. So think about that. It's a staggering number. So 2 out of 10 people with a fracture of the hip will be dead 1 year afterwards. Osteoporotic hip fractures are associated also with a 2.5-fold increased risk of future fractures. So once you have one, you're a lot more likely to have another. And about 20% of hip fracture patients require long-term nursing home care, and only 40% are fully going to regain the pre-fracture level of independence. So this is why we really aim to treat osteoporosis so that we can do our best to prevent these fractures. So fortunately, people do not develop osteoporosis overnight. So this is good. It allows us a chance to screen for it. But it happens as bone loss accumulates over time. So these are the 4 stages here. Bone mineral density can be grouped into 4 categories. Normal, we kind of touched on that. Low bone mass, which is osteopenia, osteoporosis. And then there's a category we didn't touch on yet called severe osteoporosis. And the categories are determined by measuring the bone mineral density of the patient, which correlates to the strength of the bone. So how do we know if we have osteoporosis? Well, bone loss does not cause symptoms, and it can be silently progressing over time. So an important thing to know is that the first symptom of osteoporosis is a fracture. Screening is very important in catching decreased bone mineral density so that lifestyle modifications and treatment, when necessary, can be implemented before a fracture occurs. And that's why screening with a DEXA scan, if there are risk factors, is very important. So what is a DEXA scan, you may ask? A DEXA scan stands for a dual energy X-ray absorptiometry scan, which is why we say DEXA, because that's a mouthful. This test allows us as physicians to determine the density of the bones, which correlates to their strength. And so basically what we do is we take images of the hip bones, the vertebrae of the spine, it's just the bones in the spine. And occasionally the wrist is also looked at, depending on if you have hardware in your hips. Let's say you've had a hip replacement or you have hardware in the back. We can't really do the imaging necessary in those areas, so we sometimes will use the wrist. And basically the density gets calculated after we look at that, and we use that to assess the fracture risk. So this is the actual DEXA machine. It's basically a flat table. You got a pillow there, and you have this little C arm, which if you can think about it, there's like a little C cupping the table. And that C arm is what actually delivers the very small dose of radiation needed to do this. So if you're going to get a DEXA scan, you'll lie on the exam table for about 5 minutes. Sometimes it goes a little bit longer while the exam's performed. And then I do want to stress that the radiation exposure is something people really worry about, and rightly so. But the radiation exposure of getting a DEXA scan is actually, it says similar to an X-ray, but in reality, it's quite a bit less radiation than even a normal X-ray. It's probably the equivalent of going on a cross-country airline flight. Just the radiation you get from the sun's rays coming through the fuselage of the plane, that's about as much radiation as this thing gives you. So it's really minimal. So this is an actual image that we get from the DEXA machine. So on the left, you'll see this column outlined in little kind of yellow line here. It's like you traced it, which is basically what the software is doing. But that's your spinal column. And we look at images just like this. And basically what the computer does is it gives us a density in grams per centimeter squared, which you can see on the picture right next to it. And then that converts into a score that we can use. And we'll talk about that score shortly. DEXA scans themselves, how often should we do them? So they're done roughly every 2 years. And this is because bone loss is an ongoing and dynamic process. So periodic monitoring is required. Repeat bone density scans should be done on the same machine that was originally used, as results from different machines are not able to be compared, and this is due to calibration issues. So if possible, if you've had one done before, get it done on the same machine again. If not possible, that's okay. We'd much rather have you get scanned on a different machine than to not get scanned at all. So who should get a DEXA scan? So there's multiple societies who deal with bone density and bone health, as well as osteoporosis. Some of these are the Bone Health and Osteoporosis Foundation, which is formerly the National Osteoporosis Foundation, as well as the International Society for Clinical Densitometry, or the ISCD. Each of these has a slightly different answer for who needs screening, but in general, these are the points you need to remember. Any women 65 years or older and men 70 years or older should be screened. Postmenopausal women and men ages 50 to 69 years with risk factors for osteoporosis, and we will go into some of those in a minute. Postmenopausal women and men 50 years or older who have had an adult age fracture, meaning non-traumatic, so no car accidents, no falling off the ladder. One of those falls that we say is a ground level fall. So what the DEXA results mean. DEXA scan results are expressed in different ways based on the age of the patient. So younger patients, we use what's called a Z-score, and that's for premenopausal women and men under the age of 50. And using the Z-score, the patient's bone density is compared to a young normal adult of the same sex. Basically, for those in attendance here, it's probably not the one we'd look at for you. What we would look at is known as the T-score. And so that is typically used in patients 50 years or older. All right, so I really like this slide. So T-scores are what is commonly used, as we said, to assess the fracture risk and need for treatment. So on the left here, we have the classification, so normal, low bone mass or osteopenia, osteoporosis, and severe osteoporosis, and the T-score that corresponds to those. So if you have normal bone density, the T-score is going to be greater than -1. If you have osteopenia, it's between -1 and -2.5. Osteoporosis would be -2.5 and below, and severe osteoporosis would be -2.5 and below with a history of a fracture, or -3 and below, regardless of fracture. On the right, I think this is probably the most important thing that I can tell you today, actually. So take note. So the T-score here, you can see -1, -2, -3, -4, right? Those are the T-scores. We can see the percent bone loss and fracture risk associated with each one of these. So this is pretty stunning. So if you have -1, you've lost 12% of your bone mass. and you're 2 times as likely to have a fracture as a normal person with normal bone mass. So I want you to contrast that if you have severe osteoporosis and you have -3 or -4. So -3, you've lost over a third of the bone mass and you're 8 times more likely to fracture. If you're as low as -4, you've lost almost 50% of your bone mass and you're 16 times more likely to fracture. So keep this in mind when you go to the doctor's office and you talk about your bone density scan and kind of what that means. So when to treat? So osteopenia with high risk of fracture or low bone mass and a history of fragility fracture of the hip or spine. So even if you don't have osteoporosis, but you have osteopenia, but you have high risk osteopenia, then we would treat you. And we basically determine that based on your bone density, but also on a fracture risk assessment questionnaire. A T-score of -2.5 or lower in the spine, femoral neck, total hip, or distal radius and the wrist. So we treat just based on the T-score alone there. And then, of course, we would also treat if you had severe osteoporosis. A fracture risk assessment tool, which is what we just talked about, is basically just a questionnaire, and we do take into account the bone density of the hip when we do use that tool. So here's just a little bit more information about that. So we want to treat if the T-score is between -1 and -2.5, so the osteopenia range, and the fracture risk assessment score shows a 10-year probability for a major osteoporotic fracture of any type greater than 20%, or a hip fracture over 10 years of greater than 3%. Steroid therapy is a major risk factor, so if the patient is taking chronic steroids, treatment may be indicated even if that fracture risk assessment score is lower than the typical cutoffs. All right, so in the interest of time, I'm probably gonna skip through this section because it's very rare to see young people getting a bone density scan, although we do see it. All right, so here's some of those risk factors we talked about. There's many of them. Some are modifiable, meaning that you can change them, and some are not. So some of the common risk factors: low dietary calcium and vitamin D intake, right? So those are things that we can easily modify, and we check those with our labs, okay? So we'll know if you have low calcium or low vitamin D. Hyperparathyroidism. So if your parathyroid hormone's out of whack and you're leaching too much calcium from the bones as a result of that, you can modify that through surgery. Okay, gastric bypass surgery. Some of you in the audience may have had that before. That's actually a risk factor due to difficulty absorbing the vitamins. Smoking or drinking heavily. So those are risk factors and those can be modified. Now, things that can't be modified, right? Early menopause in females, malabsorptive conditions, meaning you don't absorb food very well. Autoimmune diseases and the need for steroids to treat those. Sometimes we just can't get around this stuff. Also, family history plays a big role. And then, of course, your heritage. So non-Hispanic white folks and Asian people have a higher risk of osteoporosis than African Americans and Hispanics. And then, of course, old age. We certainly can't modify that, unfortunately. So there's also medications associated with osteoporosis. And I put this in red. I should have made it giant and bold. It's just to be aware of the risk factors. I don't want you guys going and telling your doctor to take you off any vital medications because they might interfere with your osteoporosis, okay? But it is something to keep in mind, and I'd like you guys to be aware of it. So acid reducers for heartburn, so omeprazole or pantoprazole, so Nexium or Protonix, those can do it. SSRIs, which are a form of antidepressant, and those are known to accelerate osteoporosis, and they're a risk factor. Certain diabetes medications and anti-seizure medicines, hormone deprivation therapy for cancer. We can't get around that, certainly, if needed, but it is a risk factor. And then chemotherapy in general. And then anticoagulants, believe it or not, specifically one called heparin, which we typically give in the hospital, but so that, you know, this is not a complete list by any means, but it's just an example that there's a lot of stuff out there that we don't realize can interfere with our bone density, but it can. All right, so moving on finally to treatment options. So there's a couple different flavors of options. So there's what we call anti-resorptive therapies, which we'll talk about first, and then there's anabolic therapy, which we'll talk about last. So the anti-resorptive therapies. So these basically, their job is to slow the breakdown of the bone so bone formation catches up. So they want to slow down the osteoclasts chewing up the bone so that your osteoblasts can go ahead and do their job and fill in those holes and keep the osteoclasts from breaking down too much bone. Bisphosphonates are probably the most tried and true of the osteoporosis medications that are out there. They've been around for a long time. They work very well at slowing down this process and allowing your body's natural mechanism to catch up. So you build a little bit of bone, but mainly the goal of these is to keep your bone density stable. We don't want to see any worsening of the bone density. This is typically the first type of medicine we'll use to treat kind of run-of-the-mill osteoporosis that's not complicated or severe. They're used anywhere between 3 to 10 years, depending on the formulation. So one of them, called Reclast, is an annual infusion. We use that one typically for 3 years. Sometimes we could push it out to 6. And then there's a weekly pill called Fosamax, or a monthly pill called Boniva, and we typically can stay on those a bit longer. And if the cool thing about the bisphosphonates is that they stick around in the bone. So their action on the bone takes a very long time to stop working. And as a result of that, you're able to treat a patient with these for a number of years and then stop treatment altogether and just monitor. And they're really the only medications that we have for osteoporosis that allow us to do that. Another one is Prolia. Many of you in the audience may be on this or have heard about it. It's a great drug. It's very effective. It's an injection that you get in your arm every 6 months. The one deal with Prolia is that it's not a bisphosphonate. It's not like those other ones we just talked about. So there's no period where we can stop the drug, right? You're going to lose any of the gains that you get, but you're also going to be at a risk of vertebral fractures or spinal fractures if you stop this medicine without going on one of the medicines we just talked about. So it's not to say you have to be on Prolia for the rest of your life. You don't. But if you stop it, you need to go on something else. And that's because it's so effective at stopping those osteoclasts from chewing up the bone that when it's stopped, those osteoclasts rev up really, really fast. And that's why we think that happens. Safety data goes out at least 10 years for Prolia, but there's many people who have been on much longer than that without any issues. There's a medication called raloxifene and a medication called calcitonin. These are also anti-resorptive. I'm not going to spend much time on these because almost nobody is on these anymore due to the fact that we have just better medicine. So those are the anti-resorptive therapies. We're going to move on to the anabolic therapies. So anabolic, I think of these like anabolic steroids, like Arnold Schwarzenegger. So they're going to build a lot of bone. So these are the ones that we use if you've had, let's say a spinal fracture, or if you have severe osteoporosis. We want to build a bunch of bone because we know your bones are brittle, you've already fractured, right? Or you're at an extremely high risk to do so. So these increase bone formation so that the bone formation outpaces the bone loss. So it's kind of the opposite of the other types of medicines. So the first type is called a parathyroid hormone analog. There's 2 flavors of this. There's Forteo and there's Tymlos. Both are great medicines. They are daily injections that one must self-administer. So that's kind of the one big drawback of these medicines. You can take them for anywhere between 18 and 24 months. And then this is the newest kid on the block. This is called Evenity, or romosozumab. This is a dual anabolic and anti-resorptive therapy, so it has properties of both types. So this is a really cool medicine, and it works very well. So it's great for those people who have very low T-scores or those who have fractured while on other therapies. So let's say you're on denosumab, which is Prolia, or one of those bisphosphonates, and you have a fracture despite that. I'd reach for Evenity for a lot of people to treat that. So these are monthly injections. You get it in the arm. You take these for 12 months, so a total of 1 year. And then similar to the other anabolic therapy, the Tymlos or Forteo, Evenity doesn't stick around in the bone. So really remember, the only medicine that sticks around in the bone are the first type we talked about, called the bisphosphonates. So what do we do after we're done with Tymlos or Forteo or Evenity to kind of lock in the gains that we've built on those medicines? Well, we lock them in with a bisphosphonate typically. So we would give you a year of reclast, which is the IV infusion, or we'd put you on one of the pills for about a year or so to lock those gains in. So I do want to bring this up very briefly in the interest of time, but if you Google, and most people do, side effects of these medications. So I want you to burn into your brain potential side effects, okay? Every medicine known to man has potential side effects, but these medications, they're not known to cause anything for every person. Like as an example, if you have chemotherapy for cancer, universally, everyone's gonna feel terrible, they're gonna lose their hair, all of that type of stuff. Not the case with this. These adverse events are possible, but they don't happen to everyone. So I want everyone to be aware of that. The big ones that you're gonna find for just about all of the medicines except for Tymlos and Forteo, which are those ones you inject yourself, are gonna be osteonecrosis of the jaw and atypical femoral fracture. So the risk of these is very small. So the risk of osteonecrosis of the jaw it really depends on the medicine, but I would say roughly if you took 100,000 people and you watched them for a year and they were all on this medicine, about 2 of them would have osteonecrosis of the jaw. Okay, so it's very low. Atypical femoral fracture, slightly more. Okay, if you watch 10,000 people for 1 year on the medicine, about 1 would get an atypical femoral fracture. So it's very, very rare, but it does happen. Okay. So highlights to kind of take us home here. Bone health is governed by a balance of bone breakdown and formation. Adequate vitamin D and calcium intake is essential to the process. Osteoporosis occurs when bone breakdown outpaces bone formation. Screening with DEXA scans is important to identify low bone mass before fractures happen, since osteoporosis does not cause symptoms until a fracture occurs. Up to 50% of women and 20% of men will have an osteoporotic fracture in their lifetime, and there's multiple treatments available to help prevent these fractures. So I want to thank everyone listening and watching for their time. It's an honor to be a part of this, and I'm happy to take any questions that you may have, and I'm also happy to see any of you in my office if you think that you may benefit from screening or treatment. Thank you so much.
Awesome, thank you, Dr. Benck. And I will answer some questions that came in myself right away. People were asking, could they get a copy of this? And yes, you can find this program on both the Illinois Bone and Joint Institute and the North Suburban YMCA websites in about a week. We take a little time to sort of clean it up, make sure that if we made any errors, they get cleaned up, and we will post this on both the IBJI and the NSYMCA websites. So you can check back on either of those websites and find them, and you'll also, I'm sure, find this on Dr. Benck's webpage once we get everything sorted out. So thank you, Dr. Benck. This is going to be around for a long, long time for people to view and review. All right, let's get right into the questions, if you're all right with that.
Absolutely.
Kimberly says, my grandmother and mom have osteoporosis. I am athletic and lift weights. Am I helping to ward off getting it, or am I still doomed?
Thank you for that question, Kimberly. So there is certainly a genetic component, and it's one of the questions that we ask when you come into the office is, hey, is there a family history of osteoporosis? Has your mother had a hip fracture before? With that said, it doesn't doom you to have that. It's part of the puzzle. You are doing everything right so far. Staying physically active is one of the most important things that we can do. Our bones are what I call dynamic, so they respond to stress. So if you're stressing your bones by exercising, lifting weights, jogging, even walking is great. And one thing that I will bring up here is I guess that's important to keep the bones healthy. And an example would be the astronauts on the space station. So they go up, they lose about 50% of their bone mass while they're up in the space station. They gain it back, but why you see them running on the treadmill up there isn't necessarily for their cardiovascular health. It's to help prevent bone loss when they're up there. So long story short, yes, you are doing everything right. You can certainly add calcium and vitamin D to the diet or with supplementation if you're not doing that already. Don't smoke, don't drink heavily. But other than that, it sounds like you're doing everything right, and hopefully that will be enough to kind of outplay your genetics. It might not be, so definitely get the bone density scan when it's your time. But yeah, I don't think you could be doing anything more at this point.
And if Kimberly is, say, 65 years old, she can still benefit her bones by starting weight training and putting calcium into her diet, et cetera, correct?
Yes, that is correct. I would say, you know, if you're 65, you should get a bone density scan, especially with that family history, just to make sure you don't already have severe osteoporosis or something, because sometimes that would impact what I would tell a patient they would be safe to do. As an example, you don't want to do, you know, big deadlifts or power cleans or anything where you're lifting heavy stuff over your head or straining your back if you have really low density in the back. But as a general response, yes, any time is a good time to start exercising. Light weights is always safe, even if you do have osteoporosis. And I'm not saying like 10 or 20 pounds in each arm, but, you know, very light weights should be fine. But yeah, exercise in general at any age is going to be beneficial.
Great, thank you. Marilyn asks, what if she's only doing upper body strength training? Does that help the other bones in her body? Would that help her hips or her legs?
It depends, I suppose, how you're doing the upper body. I mean, if you're holding the weights from a standing position, that stress and the strain of the added weight is going to generate through your spine down into the hips and even farther down all the way to the ground, right? But if you're doing like seated machines where you're only focusing on upper body and that extra weight isn't being distributed throughout the lower half of the body, then perhaps not.
Great, thank you. Okay, I am looking. Okay. Oh, someone asks, do you get more vitamin D from cooked salmon or raw salmon, or is it about the same?
That's a great question, and I don't know the answer. I'm gonna have to look that up because that's something that I should know. Wow, fantastic question. Yeah, I don't know.
Okay, okay.
You're
And other
probably
people
safe
were,
to eat either one, but I'm not sure.
fair enough. That's and we appreciate your honesty. So, all right. Is there ever an indication to go on treatment with a normal bone density but significant change in DEXA T-score, or is monitoring plus lifestyle, exercise, vitamin D, calcium, the recommendation, even for someone who may have cancer-related early menopause? Oh, sorry, I didn't see the end of that. That's pretty specific. But maybe just start with the.
Yeah,
Go to it.
we'll start with the T-score one. So there's plenty of patients who I see who have a normal bone density, excuse me, but they've had a fracture. So if you've had a fracture, and I know this isn't quite as specific as the question was asked, but I'll try and generalize it a little bit. But
Yes, please.
if you've had a fracture, we really throw the bone density out the window. I mean, it's beneficial for us and we monitor it, but let's say your bone density is reported as normal, but you fracture your humerus. Well, we don't look at the humerus usually, which is the big bone in the arm, right? You shouldn't fracture it. I mean, pro football players aren't fracturing it, right? So if you fracture that, it's an indication that, hey, even if your bone density looks normal, there's a problem here and we should treat you. Also, sometimes that FRAX score, this is provider dependent, meaning that not everyone does the same thing and there's some kind of mixed opinions out there. But sometimes if you have, let's say, osteopenia or even a normal bone density, but your fracture risk assessment score is incredibly high, some providers may choose to treat, some may not, and that's okay. A lot of this is art mixed in with science. And sorry, there was a second part of that question, Karen?
The second part was for someone who has premenopausal cancer.
Okay. So anytime you're treated with chemotherapy, I'm assuming that you would have been, or some sort of therapy, you are at higher risk for osteoporosis. So certainly discuss this with your OB-GYN or whoever is treating your cancer, but I think that it's not unreasonable to get a bone density scan, certainly after the age of 50. Sometimes if it's, you know, a younger female or younger male and they have cancer and they're treated, you know, we do a bone density scan just as a baseline and to see how low they are. We look at the Z-score, which is a little bit different than what we talked about, but it is important, I guess, to know overall that cancer treatment is a risk factor for osteoporosis. I guess I'll leave it at that.
Okay, great, thank you. And someone mentions that they've read that there's a possibility of calcium leaching from bones when Prolia is administered.
My guess is they're getting at transient hypocalcemia, meaning transient low calcium. I don't know that calcium leaches from bones with Prolia. If it was going to leach from bones, you'd probably see it in the serum, and I would think it would go up. When in reality, Prolia can cause a transient, meaning it's a fleeting thing, but the calcium to go down. The other medicines called Tymlos and Forteo can cause the calcium to go up.
Got it. Okay, thank you. Are there cardiac risks?
Sorry, Karen, one follow-up to that they might be getting at is that you should be taking the calcium supplements anytime you're being treated, because you need that calcium to build the bone. So I know that's not exactly what they were talking about, but I do want to just stress that.
Right. So if it's leaching out, you want to supplement so that you maintain as much as you can. I don't know that it's
leaching out. It's just that you need the calcium to build the bone that we're trying to, get built with the medication. And if it's not present, then you're not going to, get the best result.
The benefits of the medication.
Correct. And also that transient low calcium can get really low. And there's people with like dialysis patients and things that it can actually be quite dangerous.
Got it. Okay, thank you.
Yep.
Someone asks, is there cardiac risk when using Evenity?
There is a very small cardiac risk when using Evenity. We really, the way that I think about it is I take into account the cardiovascular risk factors. So if you've had a heart attack or a stroke, the label itself, says within 12 months, they don't recommend the medicine. I say if you've ever had a heart attack, a stroke, or a TIA, for me personally, I probably wouldn't give you that medicine. High blood pressure, high cholesterol, maybe if they're really uncontrolled or uncontrolled diabetes, that would raise that risk. But usually if you hadn't had a heart attack or stroke or what's called a TIA, you don't have out of control diabetes, high blood pressure, high cholesterol, then this risk is very minimal. They did see a safety signal when testing Evenity, but really it was very minimal in people that did not have those big risk factors of heart attack, stroke. So the long story short is, yes, there is a small increased risk of cardiovascular issues, and those issues would be heart attack, stroke, or even cardiovascular death. It sounds very scary. The percentages is very, very, very small if you don't have major risk factors, and I don't give it to people who have the major risk factors.
Got it. That makes a lot of sense. Okay, someone is asking, does taking hormone replacement therapy, specifically estrogen, support the bones?
It can, yeah. So if you're replacing the estrogen that you lose, it can. There's obviously, some risk with taking estrogen. So I, defer that to whoever's providing that for you. But yeah, estrogen is protective of the bones.
Great, thank you. All right, and then someone asks, are there non-drug treatments for osteoporosis?
Beyond exercise, vitamin D, and calcium, no, not really, is the long and short of that.
Okay, great. But you do have exercise and calcium and vitamin D, but it sounds to me like maybe someone ought to think about seeing you if they think they have osteoporosis to make sure that they.
There's a lot of websites out there and stuff that I've run across that they're selling a product, or they say do this exercise and you're gonna never get osteoporosis, and unfortunately I think that does a lot of people a disservice. But certainly the vitamin supplementation and weight bearing activity that's really the best non-pharmacologic thing that we have, other than those lifestyle modifications. So if you're a smoker, stop. If you're a heavy drinker, cut back, things like that.
Yeah, great, thank you. All right, is it risky to stay on alendronate longer than 5 years? I know you told us the 2 possible risks,
Yep.
She says. Does that mean you should for sure get off after 5 years if you never had a fracture?
So it's a fairly nuanced question. It's a very good question. I would say this depends on the person and how their DEXA scan is looking, how they're responding to that medicine, regardless of the fracture. I will say that the risk with alendronate, so typically you would keep someone on there for about 5 years. With that said, we often do push it out to 10 years, but when you push it out to 10 years, the risk of the osteonecrosis of the jaw and the atypical femoral fracture does go up from the percentages that I talked about. Now, do they go up to 50% or something crazy like that? No, they don't, but they are significantly higher than when you're on it for 0 to 5 years. And we usually don't ever keep people on Fosamax, which is alendronate, longer than 10 years because we recognize that there are those risks and they get too high for our comfort typically. But I would say it's not unreasonable if you have a nuanced discussion with your physician if they want to keep you on it longer than 5 years. Just hear out their reasoning, and my guess is they'll make you comfortable with whatever their thought process is.
Great, thank you, thank you. Someone asks, can you test accurately your calcium levels?
Yeah, you can. So the blood tests we have right now they're pretty accurate. I would say, you may not want to take a calcium supplement the day you get the blood test because it may make it look a little bit high. But barring that, the tests we have they're pretty good. They're pretty good.
Great, thank you. Okay, yeah. There are a bunch of questions now about exercise. You mentioned exercise. Are there certain types of exercise? I know you talked about walking, and you talked about upper body things while maintaining weight while you're doing your upper body exercises. Any other exercises you would recommend for people?
No, I mean, what we call weight-bearing activity, it can be as simple as just walking. I mean, really what we're looking for is the weight of gravity on you. So the way I think about it is don't be a bump on a log, don't be a couch potato. If you're out and you're moving, if you're walking, you don't have to be lifting heavy weights. A lot of people can't run, but if you're just moving, that's really, it's probably adequate from that standpoint. If you can add a little something to it and your doctor tells you they're okay with it because, again, some osteoporosis is quite severe. We may have another condition where you shouldn't be lifting heavy weights. It's always a nuanced discussion between the provider and that individual patient, but overall, there's no specific, regimen that's better than another one. Really just be out and be moving.
And weight bearing.
And weight bearing.
So maybe not just moving, sitting in a chair, but getting up, like you said, be out, be moving. People ask about pool exercises and riding a bike.
Yeah, I mean, those are good. They're not probably what we would call weight bearing. I mean, pool exercise, I guess, to a small extent, but really, the buoyancy of your body in the water is going to kind of counteract a lot of the gravitational forces, which is what we're trying to, have act on the bone. With that said, if that's all you can do, that is better than nothing. And, just for your overall longevity, health, and how you're going to feel, I would strongly encourage you to keep doing that. Bike riding, again, really good for muscles, for joints, just for fun. But I don't know if it would be considered weight bearing.
Gotcha. And I've heard that even by utilizing your muscles, you're putting stress on your bones, which can help build bone strength. So riding that bike, you are using those muscles around your legs.
Yeah, and that would maybe go towards like the hip. It's not going to probably go to the spine, although your core is activated and things of that nature. But again, anytime you're being active, I'm happy. Again, like I want to stress that we do our best to kind of avoid osteopenia and osteoporosis by doing these activities. But for the vast majority of us, even if we're extremely active, and I have a lot of patients that are, and they still get this disease. So we do the best we can. But I do want to stress that, it's not a foolproof solution. And don't beat yourself up if you get it. If you've been doing everything right with your calcium, your vitamin D, and your exercise, and you still get that bone density scan, and we tell you, hey, it looks like you probably need treatment. I don't want anyone to beat themselves up because, you're doing everything right. A lot of this stuff is not preventable. A very large portion of it is just your genetic makeup.
And would you say for people with young children or their grandchildren who are sitting like this all the time on their phones, you talked about building bone density until your 20s or 30s. that's really when they should be getting up off the couch and getting off the computer and building bone density, right?
Inactivity is a massive problem with younger folks today. I mean, we see it in the, the obesity statistics and things of that nature. So yeah, I mean, they need to be out being physically active, running, jumping, playing, that kind of stuff is very important.
Great,
And that's
great.
not just for bone density. But yes, you're right. If you're just kind of sitting there doing not a whole heck of a lot, while your body should be building that peak bone density, yeah, you're right. You're not going to build as big of a peak, and so you're going to be a lot more likely later on in life to develop osteoporosis.
Great. Yes. Thank you. Thank you. All right. And we clicked into 8 o'clock. And Dr. Benck, we want to be very respectful of your time. Thank you, everyone who joined us tonight. Thank you for all your wonderful questions. And most of all, thank you, Dr. Benck, my favorite IBJI doctor. Yay. Thanks for a wonderful presentation tonight, Dr. Benck.
It's my pleasure. And thank you all to the audience members for your great questions and just coming to take a listen. And hopefully I'll see some of you in the office for a bone density scan.
All right. Take care. Thanks. Good night, everybody.
Bye-bye.